The Washington Manual of Surgery podcast is based on the 9th edition of the best-selling Washington Manual of Surgery.
This podcast is meant to condense key topics from our manual into bite-sized episodes for your convenience. Now, on to this installment of the Washington Manual of Surgery podcast.
Hello, everyone, and welcome to the Washington Manual of Surgery podcast. We bring you everything you need to know about high-yield general surgery topics built for your just-in-time learning. On this episode, we're thrilled to have Dr. Ryan Fields here to review the management of skin and soft tissue malignancies. Dr. Fields, do you mind introducing yourself for our listeners?
Yeah, Ken, thanks for setting this up and having me. My name's Ryan Fields. I'm the Chief of Surgical Oncology at Washington University and Siteman Cancer Center.
And my name is Ken Newcomer. I'm a PGY4 general surgery resident here at WashU. I will be your host for this episode. Today, we're going to review skin and soft tissue tumors, focusing on topics that are most relevant for surgery residents. We will discuss primary skin cancers, especially melanoma, and we'll briefly touch on soft tissue sarcoma and sarcoma-like tumors, but the full extent of that topic would be outside the scope of this episode. Let's jump right into a case scenario to guide our discussion. So, Dr. Fields, a 60-year-old man presents to your clinic with a pigmented skin lesion on his right thigh. Do you mind quickly reviewing the most important clinical points on history and physical?
Yeah, so of course you're going to get into a lot of the aspects of how long has it been there, has it been growing or changing, and really if it's something that became symptomatic, meaning why are they seeking medical attention for this? Or if you just happen to notice it on a routine exam incidentally, then some questioning on that sort of history. Although family history is sometimes relevant for these things, it's not all that important, but you probably want to ask about it, especially if you're sitting in front of your oral boards and that sort of thing for completeness. And then in terms of physical exam, it's really characterizing any pigmented lesion with what we sort of talk about and the mnemonic people always mention is A, B, C, D, E. You know, is it asymmetrical? What's the border look like? What's the color look like? What's the size? Has it evolved over time? Of course, that's a question more than a physical exam. And then for any skin lesion, doing a good comprehensive regional lymph node examination is going to be key to part of that examination.
And often the next step for any suspicious pigmented lesion would be a full thickness biopsy. So let's say this patient, as is often the case, has already seen a general practitioner or a dermatologist and has had their lesion biopsied with an excisional or a deep shave biopsy. What are the elements of that pathological review that are most important to you?
Yeah, so I'd say, there's a couple aspects even in backtracking, because a lot of times you might be asked, well, what type of biopsy are you going to do? And if you can biopsy the whole lesion, meaning if it's, a smaller lesion, a centimeter or so in diameter, then a deep shave or an excisional biopsy would be appropriate. Punch biopsies can be used too, up to lesions about that size. Oftentimes, two punch biopsies may be used for the most concerning part of a larger lesion. So let's say someone came in with a really big lesion, 5-6 centimeters of birthmark that they said, was starting to grow or change. You may direct them or an examination may direct you to a particular part of that lesion to do a punch biopsy rather than excise the whole thing straight away because you wouldn't know what margins to use appropriately. Now, if you get to the point where you've biopsied a pigmented lesion and I'm assuming it's coming back something melanocytic, is that? So I think if it's diagnosed as a melanoma, then what you're really interested in are some of the features of the melanoma, really the depth, of course, Breslow depth, named after the pathologist who really characterized these lesions initially. You want to know some microscopic features like ulceration. One thing that's sometimes confused, ulceration is not a clinical diagnosis. It's not looking at it and calling it an ulcerated lesion. It's something the pathologist tells you under the microscope. And then although they're not important in the AJCC staging for all depths of melanoma, you want to know the mitotic rate. You want to know if there's lymphovascular invasion. Those are really the main prognosis driving factors.
And moving forward then, the next step would be to stage this person's melanoma. The exact TNM staging can be reviewed through the AJCC. The most recent 8th edition guidelines have extensively subclassified stage 3 melanoma due to a broad range in outcomes in the setting of modern systemic therapies. An overview of important staging information can be found in the Washington Manual itself. It's worth, for surgery residents, it's worth looking at a more granular description of the staging if you have time to do that. I'm just going to summarize in a few sentences the TNM staging. And Dr. Fields, feel free to chime in here if there's anything you'd like to add or corrections that you want to make. The T category is determined by Breslow depth and tumor ulceration, like you just mentioned. N category by the extent of lymph node metastasis and the number. In-transit disease and satellitosis also factors into N staging. And then M, of course, refers to remote metastases. Stage 1 and 2, for the most part, refer to local tumors and are classified by the T category. They do not have any distant disease. And important cutoffs to keep in mind for tumor depth are less than 1 millimeter traditional thin melanoma being T1, 1 to 2 millimeters T2, 2 to 3 millimeters T3, and anything greater than 4 millimeters of depth is a T4 tumor, sometimes called thick melanoma. The A and B designation of the T stage refers to the presence or absence of ulceration. Stage 3 tumors are regionally advanced, and they are defined by the presence of lymph node metastasis. Stages 3A through 3D have progressively worse outcomes and progressively increased primary tumor size and lymph node bulk. The precise definition of each one of those is something that is probably best reviewed on a chart of the AJCC guidelines. So let's say our patient has a 0.8 millimeter thick melanoma with no ulceration and no evidence of disease anywhere else. No other imaging or labs are indicated. Most residents will know that the next step is a wide local excision, including the full depth of the dermis and often as deep as the muscle fascia. Can you talk briefly about resection margins and sentinel node biopsy?
Yeah, so this is a good illustrative case. Before I get into the details of that, I'll just backtrack into some of the staging things because there's a couple pearls that I think residents can keep in the back of their mind. One is, although this isn't perfect, you can kind of think of the depth of the melanoma as predictive of the risk of having a positive sentinel lymph node, roughly speaking. So a 1 millimeter depth melanoma will have about a 10% risk of a positive sentinel lymph node, a 2 millimeter 20%, a 3 millimeter 30%. It's not linear, but it's a good way to think of it in your head roughly. And the presence of ulceration in that primary tumor will increase that number by somewhere between 5 and 10%. So it's just a rough way to think about it. Okay, if I have a T2, if I have a 2 millimeter melanoma, 20% or so. If it happens to be ulcerated, it's more 25, 30%. So just a good way to think of it in the back of your mind. The other aspect of the staging system that's quite interesting is if you told me, Dr. Fields, listen, I'm sorry, but you're going to be diagnosed with melanoma tomorrow. Would you rather have a stage 3A melanoma or a stage 2B or C melanoma? Instinctively, people would say, well, stage 2, it's lower. But the curves and the outcomes of stage 2 melanomas, which if they're B or C are driven by the presence of ulceration, is a lot worse of a prognostic risk factor than, say, having one single positive sentinel lymph node with less than a millimeter of melanoma in it. And it's hard to wrap your head around that, but that ulceration is a key driver of prognosis. So just because it's stage 2, especially stage 2C, those carry a higher risk of recurrence than a stage 3A melanoma. Stage 3A melanoma patients do very well. So that's just sort of a couple pearls. If we get into that particular scenario that you brought up, this is a patient that when they have a melanoma that's technically T1, but because it's between 0.8 and 1 millimeter in thickness, it gets that B designation, not because of ulceration, but because of depth. And the reason that category was created, the T1B category, is because those patients technically have thin melanomas, but have a little bit of an elevated risk of sentinel lymph node positivity. And so if you think of that, there's a distinct group of melanoma patients that you would really never recommend a sentinel lymph node biopsy to, and those are the T1A patients. Now, every once in a while, you'll get a T1A patient that, say, has a very high mitotic rate or lymphovascular invasion, very young age, things that if you put into some of these risk prediction algorithms or calculators, which are very helpful, may have a higher risk of melanoma, and you may recommend a sentinel lymph node biopsy every once in a while. On the opposite side of the spectrum, generally, if you have a melanoma that's Breslow depth of 1 millimeter or greater, you're usually going to recommend sentinel lymph node biopsy because their risk of sentinel node metastasis is up in that 10%-ish range. But there's this group in the middle where they have a melanoma that's a depth of 0.8, 0.9. And this is a large number. A lot of people are diagnosed with these early melanomas where their risk of a positive sentinel lymph node is between 5 and 10%. And younger patients have a higher risk, older patients lower. So when you see these, say, 30, 40-year-olds who've had sun exposure over the years, maybe they use tanning beds that have a early melanoma that's 0.9, but an elevated risk of sentinel lymph node. So what the guidelines would say is discuss this with the patient. So, and that discussion involves the risks and benefits of sentinel lymph node, use the concepts of shared decision making, and come up with a plan. So the Society of Surgical Oncology, the American Cancer Society, the American Society of Clinical Oncology have come up with these joint guidelines that recommend discussing sentinel lymph node.
And can you talk quickly about resection margins?
Yes. Oh, yeah. So margins, generally what a pearl for that is a melanoma less than 1 millimeter in depth, 1 centimeter margins are adequate. For a melanoma over 2 millimeters in depth, 2 centimeter margins are adequate. Then and the reason we have those firm recommendations is there are very good randomized clinical trials that have come up with those guidelines that support those guidelines. Then there's this intermediate category of melanomas between 1 and 2 millimeters where the recommendation is margins between 1 and 2 centimeters because there's subsets of clinical trials that have addressed that, but no specific level 3 high-level data to make firmer recommendations, although there are some trials underway. Same thing on the thicker side. There are some people who might advocate for wider margins for deeper melanomas, but that is not supported by high-level data. So that's kind of the way I would approach it. In that gray area of 1 to 2 centimeters, I generally advocate for 2 centimeter margins if they're feasible without a cosmetic issue or need to do a skin graft or flaps, things like that. You do run into this in cosmetically sensitive areas, on the extremities even, say over the hand or the wrist where there's not a lot of tissue laxity, those sorts of things. The other principle that is really important to adhere to, whether you're talking about an initial biopsy that's excisional in nature or a definitive resection, is when it's on the extremity, you want to plan that parallel to the axis of the extremity, meaning no horizontal excisions and horizontal biopsies. And the reason is that you can think if you had to come back to then re-excise to do that in a horizontal plane on an extremity will almost always result in a skin graft.
Well, thanks so much for a really thorough review of that topic. If we come back and revisit our patient here and say you do a sentinel node biopsy and a complete wide local excision for that patient with negative margins, what if one of those sentinel nodes was positive for occult metastatic melanoma?
Yeah, great question. And of course, that upstages them to stage 3, at least stage 3A. If there's more than one lymph node or other associated features with the primary tumor, say an ulcerated primary, they could get up to stage 3B, stage 3C, that sort of thing. But at the very least, they're 3A. And the way I usually think about it is, okay, this melanoma has shown the ability to spread. Let's make sure we don't see anything more than just a positive sentinel lymph node. So that's usually a trigger for a staging workup that involves some amount of imaging, either a PET CT scan or a CT scan of chest, abdomen, and pelvis. Generally, for a 3A melanoma, outside of symptoms, we don't necessarily mandate a brain MRI. But for 3B or higher, the risk of occult asymptomatic brain metastasis goes up quite a bit. So 3B or higher, generally a brain MRI. The reason a brain MRI is a CAT scan, although is good, is not great for small lesions, and a PET scan, of course, doesn't really image the brain. So some sort of dedicated brain imaging. And that kind of segues into another topic, and that would be what would be the reasons you might get imaging studies before taking a patient for wide excision sentinel node. What most of the guidelines would say is if you have somebody with a T4B primary tumor, so that would be a melanoma over 4 millimeters in Breslow depth with ulceration, that probably warrants a staging workup beforehand because their risk of clinically occult metastasis is going to be significantly higher. Some people would advocate for a staging workup of potentially an ultrasound or even more in a patient where a clinical exam was very challenging, say a very obese patient where you can't really do a good groin examination for an intermediate or higher risk melanoma. And then, of course, for symptoms, if somebody came in with a new melanoma, like even the patient you said with their thigh, but were having some unexplained symptom that you were worried could represent metastatic disease or the like. And then, of course, you get into the question of management after that workup. So in most of the patients with a 3A melanoma, you're still going to get a negative PET scan or negative CT scan, and then it's what do we do next?
And that's a perfect segue into our discussion about nodal bed surveillance and surgical management of occult metastatic disease. We could mention at this time the MSLT trials and the DCOG trial, which we wrote about in the chapter in the book.
Yeah, these have been landmark studies. I mean, melanoma is fortunate to be one of the poster children for well-controlled, well-done surgical randomized trials. And so MSLT1 really set the stage for the utility of sentinel lymph node biopsy as being the strongest predictor of melanoma-specific survival. MSLT2 then asked the question of what do we do with a positive sentinel lymph node definitively. So the background would be MSLT1 basically said everyone with a positive sentinel lymph node, the next step in treatment would be a completion lymph node dissection, removing all the lymph nodes in that nodal basin. And what we learned from MSLT1 that although that worked very well, the risk of having additional positive lymph nodes after a positive sentinel lymph node biopsy was really only about 16%. And so you were treating a large number of patients, 84% of those patients, with no benefit. You were getting good prognostic information, but you were removing all the lymph nodes. And of course, with doing a complete lymph node dissection, you have long-term risks, most notably of lymphedema. And for particular areas of the body, especially in particular patient populations, say a groin dissection in a person who was diabetic, smoker, and obese, that's a really high-risk operation for wound complications, for DVT, for long-term lymphedema. So not an operation you want to be doing if there's no clear benefit. So what MSLT2 then asked the question is, well, what if we take patients with a positive sentinel lymph node, like the patient we've described here, and we randomize them to completion lymph node dissection versus nodal observation? And by the MSLT2 trial and by a German trial that was called the DCOG trial that I'll just mention supports the MSLT2 findings, although it was stopped early. But the MSLT2 is the larger, more powerful study. What the MSLT2 trial said is let's take half of these patients and randomize them to completion lymph node dissection. Let's take the other group and randomize them to nodal observation with clinical exam and frequent nodal ultrasounds to look for architecture and suspicious lymph nodes. And that was over a 2-year period that they would do these more intense surveillance routines. And the long story short is they were equivalent. And what that really taught us is if we follow patients closely and we identify nodal disease that comes up later, that it doesn't result in inferior outcomes oncologically. And what it does is it spares a large number of patients an unnecessary completion lymph node dissection. And probably the thing people worried about the most is they would say, if melanoma pops back up in a lymph node, does that mean that it also has the chance to spread to distant organs? And they did not see that in the MSLT2 trial. So there was you didn't lose a window of opportunity to treat a patient that then became metastatic in the follow-up of this trial.
We hope you enjoyed this installment of the Washington Manual of Surgery podcast. Stay tuned for parts 2 and 3 of this episode, which will cover further aspects of the management and surveillance of cutaneous melanoma, as well as other skin and soft tissue tumors. We are Drs. Paul Wise
and Jeff Blatnick,
senior editors of the Washington Manual of Surgery. We'd like to thank the residents and faculty of the Department of Surgery at Washington University Medicine, and we'd especially like to thank our associate editors for this edition, Drs. Catherine Caldwell, Ina Chen, Bradley Kushner, Martha Bucky McGilvray, and Jorge Zarate Rodriguez.
We hope that you enjoyed this episode of the Washington Manual of Surgery podcast. For more comprehensive information in a brief outline format, check out the print and digital version of the Washington Manual of Surgery, published by Wolters Kluwer Health and Lippincott Williams & Wilkins. Please search online for the Washington Manual of Surgery 9th edition to purchase your copy of the manual.
To learn more about the educational opportunities available in the Department of Surgery, please search General Surgery Residency at Washington University School of Medicine in St. Louis.